Welcome to the Rimm-PODCAST, episode 60. This particular episode will be around the gap between the doctors and legislators, and also gap between the doctors and the prescriptions and the patients. We want to bring it up to the light in the nation, in the Central Florida, and I used to work with a lot of doctors when I was a pharmaceutical rep. Doctors are hardest working people in the world, and they are totally disconnected with the legislators because legislators also work so hard. I said it's my job to connect you guys together either through the Zoom call or through the online, virtual, and so on and on. So your special host, Tiggy, I love to start introductions by the Dr. Safi. Dr. Safi, can you tell us a little bit who you are, where you're coming from, and a little introduction about you?
Sure. My name is Farhad Safi. I'm a vitreoretinal surgeon. So I'm an ophthalmologist with specialized training in retina surgery. I just moved to Central Florida about 5 months ago from Hawaii. I'm in the process of transitioning between careers, and I'm very happy to be amongst such an esteemed group of doctors.
Thank you, and thank you for your service.
Thank you very much.
Now let's go with Dr. Patel. He's a trauma brain injury. Dr. Patel, tell us a little bit about who you are.
Good evening, everyone. I'm a neurologist by training. I finished my training in 2009, and since that, I have been in Tampa. Initially, I was more like a neurohospitalist, stroke director, and last 7 years, I've been practicing more like a private practitioner and focusing more on TBI, evaluating the ex-NFL player, NCAA players, personal injury, brain injury, veterans returning from the combat. So primarily focusing on the TBI on the side of the general neurology. So I'm glad to be part of this group. So
thank you for your introductions. I like to having you. Thank you for joining us. And now we have a Dr. Neil Brown. He also have a medical degree, but also PhD. He was 250 depositions done his lifetime. Doctor, tell us a little bit about you, who you are, and all your expertise behind you.
Okay, I'm Neil Brown. I finished my neurosurgical training in 1996. So I'm really in my 26th year of practice now. Trained in Canada, so it's a bit more conservative than the U.S. Different medical system, obviously, as well. But basically, as time has went on, I was fairly general, doing cranial as well as spinal neurosurgery, and then have transitioned mostly to outpatient spinal surgery. Although I will still do consultations on other aspects like closed head injury as well. So that overlaps with Dr. Patel. And I also have a PhD in medical biophysics. So I'm commonly asked to provide both neurosurgical and biomechanical expertise to certain cases.
And Doctor, thank you for joining us. Today will be a great discussion. I want to go straight forward. If you have any comments you love to ask, cross asking each other, and please let us know. My first question as a doctor, as being in your field, what are your views on the current healthcare system? So we'll start with the Dr. Neil Brown.
Well, I'm a bit biased just because I did train in Canada. In Canada, healthcare is ingrained within the Constitution, so it's really paid for by people's taxation. So that's probably why the taxation is higher in Canada. So there's no out-of-pocket for routine visits or surgeries in Canada. And I do like that system. Just because you hate to put a financial price on somebody's health care,
Of course.
Whether you're poor or rich, you still need the same type of health care.
Perfect. What about you, Dr. Patel?
So for the healthcare, I'm in the early career, compared to Dr. Brown and Dr. Safi, but from my limited experience with this, being a solo practitioner for last 7 years or so, the problem or difficulties I've been noticing to help the patients. Sometimes I see the patient, they don't have insurance, uh, they can't afford any testing. I have been doing some of the self-pays, giving the charity kind of work. I don't get paid, but I try to help. But the bigger issue I've been noticing, and that's why I diverted my practice more towards this TBI, which is I deal with this all medical legal stuff where I don't have to worry about more insurance, because the area I practice in Tampa is very saturated and it's hard to get the good reimbursement with the insurance game. So it's hard to get help each and every patient. So that's the trouble I have been getting. Another issue is, I'm sure everybody here noticed, is the prior authorizations, which is the nightmare. I have specifically assigned the one person to take care of the prior authorization for all the new testings and so on. So, which is the big expense with dedicating one person. At the same time, the reimbursement is going down. So you have to work a little bit harder than you should probably for to make up those costs. So those are the common things. And also the one big issue I've been noticing, because of the TBI and the headaches, I've been trying to prescribe the newer medications for migraines, which are great to help the patient. But the same thing, the prior authorizations and coverage is the bigger issue. So it delays the care of the patients. They deserve the better care, but all the legislation issues delay the patient care. So
Perfect. Thank you, doctor, for your insights and inputs. What about you, Dr. Safi? I know you moved from Hawaii. Now you're transitioning to Florida. You're probably seeing an even much bigger impact on you.
I have. I echo what my colleague said. There are many issues in healthcare that we probably couldn't even summarize in the time allotted. Certainly, we have problems. We don't have a perfect system. I don't think anybody has a perfect system. In Hawaii, I treated Canadian patients who would rather have their surgeries in the U.S. for cash rather than wait, 11 months, 12 months to see a subspecialist. So we could learn and kind of adopt the best practices from different health systems, perhaps to our health system. But we do have a lot of challenges: access to care, cost of care, cost of pharmaceuticals, legislation that imposes costs on physicians. At the same time, as Dr. Patel said, reimbursement is going down, and doctors and practices feel like they're getting squeezed by burdensome regulations, whether governmental or from insurance companies.
Okay, perfect. So I want in my next questions, because I'm gonna interview a lot of legislators moving forward on the federal level, state level, House representatives. I want your inputs as a doctor, seeing the patients on daily basis. What are your biggest challenges behind the health system? If you can implement that or improve one particular strategy and idea, what that would be? I'll start with the Dr. Patel.
yeah, so going back to the same thing as I mentioned earlier, is that the biggest issue, at least in my practice, and I'm sure my colleagues would agree, is that the as a doctor, we are trained, we go through hard training, and doctor should have right to dictate the what patient needs or not, rather than insurance imposing that somebody non-medical degree person governing that, okay, you should have this kind of test, MRI or not, this person should have EMG or not. So that rather than those person deciding, doctors should have that authority and get rid of or find the solutions, especially the prior authorization. That's the biggest hurdle I have been noticing
Okay.
in my practice. Yeah.
Okay, and thank you for the inputs. We'll definitely spread your message to the legislator, with the hope they will listen to you and all of you guys are moving forward. What about you, Dr. Neil Brown?
Well, I think I'm also transitioning because had been practicing for a number of years in Colorado, so just recently moved back full time to Florida.
Welcome to Florida.
So I'm not up and going yet. It's a transition. I have hospital privileges. I have surgical center privileges, but it's really a transition. And I must say, in terms of, the decrease in reimbursement and such, it doesn't affect me much at the present point, since I'm not taking insurance. I'm primarily doing medical legal work. So that doesn't really affect my practice that much in terms of reimbursement. And by doing the medical legal work, I actually can afford to spend time with patients. I'm atypical as a neurosurgeon, spending 45 minutes to an hour with new patients. Again, because I do medical legal, there's much more detailed history that is necessary for that type of practice. You get the same care, it's the same operations and such if you recommend surgery, but I just get to spend a little bit more time. And unfortunately, people that are confined to insurances, just because of their overhead, they have to see too many patients to provide good care.
Okay, thank you, Doc. What about you, Dr. Safi? If you can do one thing for a legislator beside all of the experience, especially on the multiple transitions between the city, different laws, different oppositions, what would you tell them that we can send a positive message to our legislators?
I would say the scope of care. In the past few years, there's been more and more scope creep of other medical professionals, perhaps encroaching onto surgical fields. For example, in Oklahoma, or was it Kentucky, and recently in California, state legislature passed bills that would allow optometrists who are eye doctors who are not specifically trained in eye surgeries to perform incisional scalpel eye surgeries. So this is where I think the legislators as well as the public needs to be educated on the differences between surgical training and training for other healthcare professionals who are trying to expand their scope of practice, and informing the legislators how important it is for patient safety and for patient care that surgical privileges should not be legislated. They need to be earned. There has to be rigorous training and testing before people are allowed to perform surgery, especially incisional surgeries with blades and scalpels. So that's kind of an important issue for us as ophthalmologists.
Perfect. Thank you, Dr. Safi. My next question, if one of you can do, if we are keep doing the way we are going with the same track, how do you see the future healthcare system in our country? I'll start with Dr. Brown.
I think if things continue the same way, I just see the quality of healthcare deteriorating, because physicians will not be able to spend enough time on the patient and to focus on them properly, diagnose them, understand what they're treating, and go forth. I think it's, unfortunately, with cost considerations, overhead never goes down. So those are always going to be a cost, and actually the increased cost with inflation. And then you have decreasing reimbursement. The only way around that is to either find other avenues of financial income, or unfortunately spend less time with patients. And I don't think that's a good idea.
Okay, thank you, Dr. Brown. What about you, Dr. Safi?
So cost of healthcare has been rising faster than inflation in general for the past few years. And this is imposing huge burdens on families for the cost of insurance, healthcare, deductibles, medications. And on the current track, I don't think this is sustainable long term. And this will need a societal debate on where we want to go as a country. And this is obviously a very hotly debated political issue: single payer system versus private insurance, or perhaps a hybrid of the two. Both a single payer system like they do in Europe versus the UK or Canada. But I think something needs to be done to improve the situation.
Perfect. What about you, Dr. Patel?
So I agree with my colleagues, Dr. Brown and Dr. Safi, and to add the point on the future providers, healthcare providers, what I have noticed and already started seeing the trend, at least the several colleagues that I know, even they after graduated, did fellowship, they did not practice in a single day. They just diverted their business. They went into different business. I have seen the people like they finished the med school and they did not practice. So they did not go for residency. Some of the people I've been talking young generation, I'm trying to convince them to go to medicine to help the people. And they say rather we start something else when we are young. By the time we reach to when we finish the training, we are far ahead than the doctors practicing. So in short, the shortage of doctor is already there and is going to get worse, in my opinion, if the trend continues this way, especially the rising cost of the overhead expenses and decreased reimbursement. So, yeah.
Okay. So right now, I know there was a big digital transition back in time when you have to now report everything digitally. And then from the administration point of view, it takes so much for you guys to focus on the patients rather than filling out all the paperwork. So how much that did affect your impact? I will start with the Dr. Safi.
So transitioning to electronic health records and reporting, outcomes or billing and coding electronically, it was meant to reduce cost, reduce medical errors, increase efficiencies, improve communication between doctors. Unfortunately, the way it was implemented was a patchwork of different electronic medical records that don't always talk to each other. And the net effect in some cases has been increased cost, but no improvements in efficiency, or actually worsening efficiency for physicians. And this is, again, a system that has been kind of a patchwork of different softwares and different programs versus a single system that everybody can use, that can talk to each other truly, between doctors and hospitals and so forth. So I don't think it has turned out the way that it was originally intended, in my opinion.
So it was not cost effective as they thought about it should be.
Because of, if you look at how much electronic health records cost the hospitals, some hospital systems pay tens of millions of dollars to acquire these electronic health records, to maintain them, to hire IT departments and stuff. So in my opinion, it has increased delivery of healthcare to patients.
Okay. What about you, Dr. Patel?
Yeah, I agree with Dr. Safi. And from the physician perspective, as he says, the efficiency is significantly down. None of the system is perfect. There is always something that you want to improve. Most physicians, at least that I know, my colleagues, we spend like a lot of time in administrative work after seeing the patients, after hours, when you are home, finishing the notes and sending the fax, receiving the fax. So it takes a lot of time from your personal life. So of course, a lot of administrative expense and takes away your personal life and pleasures, and that leads to the burnout in the physicians. So,
And giving the less time for the doctors
yeah,
to practice the time within the
yeah, of
patients,
course,
vice
definitely,
versa.
yeah.
Okay. What about you, Dr. Brown?
Well, I've since I've transitioned mostly to outpatient surgery, it hasn't been as much of a hurdle for me because electronic medical records really aren't a big thing in outpatient surgery. So really I'm just able to do things I just did before. It's a struggle when want to have to do stuff in the hospital because, if you're not doing a lot there, to keep up with all the changes, like some of these systems, they'll have revisions every month. And if you haven't been there for a couple of months, you can be in the dark. And I agree with Dr. Safi. This has actually decreased efficiency rather than improved efficiency. It's really quite cumbersome for people. So that, has been one of the reasons why I've, went to more of a medical legal practice, so I don't have to deal with that nonsense. Everything worked fine for me before. Maybe I'm a dinosaur, but it worked.
Actually, it's Dr. Safi again. I agree with Dr. Brown. This is a very good illustration. Hospital operating rooms that are mandated to use electronic health records versus ambulatory surgery centers where they don't have to. There was no requirement for them to have electronic health records. And I operate both in a outpatient ASC and at the hospital. And the time it takes to complete paperwork after surgery or before surgery for patients at ASC is several times less than at the hospital. Paper electronic or paper medical records are a lot faster, a lot easier for a physician. We can look at a picture or a drawing that we had in clinic, and that can tell us a lot more than pages of electronic health records can. So this is one area where some physicians are driven away from hospitals to outpatient ASCs.
Okay, thank you for your inputs. Now, we are a state of the Florida. There is a lot of abusive elderly care. What do you see? What kind of care does an elderly clients receive and need it to sustain moving forward? Like I said, 8.6 million elderly patients or elderly people living in the state of Florida. That means almost 40% of our population. It's in there, close to 40. So what do you see? Because probably you, Dr. Safi, because the majority of the people with macular degeneration and degeneration, because over the age we deteriorated. So I will start with you. What do you see? What kind of care we should bring in the state of Florida that our elderly patients and elderly care citizens are a little bit having a better healthcare system here?
Right. I am by no means an expert on this. I've only been here a short amount of time. But from what I've seen, like you mentioned, the majority of my patients, especially in outpatient setting for macular degeneration or elderly people, and there are many, many issues in accessing care, transportation, managing the healthcare system, advocating on their own behalf to acquire the pharmaceuticals that they perhaps need. These are very, very difficult. And also the cost of buying or paying for healthcare services and medications sometimes can mean the difference between paying for their basic needs versus paying for a doctor visit or a prescription medication. So this is, in my opinion, again, there's different insurances with different deductibles and stuff. And sometimes it's very difficult for seniors to navigate it. And choosing the right plan to make sure that the plan that they have chosen is the right one for their specific needs. So there's a lot of improvement to be made in providing access to care for our elderly.
Thank you, Dr. Safi. What about you, Dr. Patel? I know you're a neurologist. I know you also deal on the trauma brain injury, but there's a lot of patients with dementia disease, and because we're getting old, we're using a lot of neurons each and every day, so we're getting old. What about you? What are you seeing, not just now, but before even I used to work for the Tampa Hospital?
So the elderly populations, like as far as to add the point in Dr. Safi's thing, he pointed out the accessibility of care. Like as you said, like they have difficulty choosing the right plan. Maybe they don't understand, or there's the insurance isn't. We may not be explaining properly. So what I have seen in my practice is that a lot of people are getting diverted from state Medicare to like Advantage plans and so on. They get some benefits upfront, But when they really need the care, especially neurological care, they have a hard time getting approvals. They have to come out of their out-of-pocket costs, which even like minimal, a few dollars, but it's big for them because they are retired, they have no source of income. So it delays their care, and probably it can affect their, it can have the adverse consequences if they delay the care. So accessibility, insurance, choosing, that's the biggest hurdle I have noticed in my practice from the elderly.
Okay, thank you, Dr. Patel. What about you, Dr. Brown?
Actually, I have a little story. I frequently give my cell number to patients, for them to contact me if there's any issues after surgery or anything like that, or any questions. And I had treated a patient many, many years ago in South Florida. Currently, I'm in the Tampa area, and this pleasant 94-year-old woman who I'd never ever heard of before. Apparently, one of the patients I treated gave her my number, and she called me and wondered if I could treat her. Well, that's not really possible from Tampa to Broward County or Palm Beach County. And she really started explaining all the difficulties she's been having. She said all the private physicians in South Florida are being bought, their practices are being bought out by the hospitals. So she can't get in for an appointment. It's just a logjam for her. So I feel really bad for this, very pleasant 94-year-old woman who is sharp as a tack. She needs help, but she can't get it.
Wow, so no access. So our last question, we are almost closing to the 30 minutes. This is gonna be really probably one of the best questions. Let's say you are having a chance to go to the floor at the Florida state legislators, and you have 2 minutes or a minute and a half each to convince, as a doctors, what is your biggest challenge? And in your best description that you can describe, there's this 120 legislators having a chance to listen to you, and now they will listen to you. What would you tell them? What would be your biggest challenge, and what would you convince them that this is, we are doctors, we are dealing with the patients, we are curing the patient. Not just that, but you also treat the legislators too. When they get sick, they guys get to you. So now you have a chance to go on the floor, and the floor is yours. What would you tell them to improve the better healthcare system? You got 60 seconds. We'll start with the Dr. Brown.
I think the main thing is competency of the people in insurance making medical decisions. Some of these employees may only have high school education with no medical background, yet they're the ones making the decision whether or not a patient has access to care. And that's completely inappropriate. It's the same type of thing. Uneducated people, or at least not educated in the medical field, people denying procedures for patients just to save money for the insurance company when they don't have the appropriate education to make those decisions. I think those simple things would improve care if they were corrected, because physicians can't have a person or multiple staff always doing appeals upon procedures. That takes up a lot of time and resources that is better spent on patient care.
Okay, so perfect. What about you, Dr. Patel?
Yeah, so for me, I would just say that let doctor be a doctor, because to become a doctor, you have to go through vigorous, extensive training, as Dr. Safi mentioned. You have to pass the different exam, testing, supervision, and so on. It's the lengthy training, and that's how you become doctor in practice. And one perfect example, what we have noticed, at least in my neurology practice, that some of the colleagues, like few years ago, at least 6-7 years ago, there was a big cut in the reimbursement, particularly like NCV and EMG, which is the neuro testing, which is the bread and butter for neurology to diagnose and treat the patient for neuropathy, different type of neuropathy. And there is like 60% cut in reimbursement. And each test takes, if you do like quality proper test with the controlled environment, it takes 45 minutes to an hour, and the reimbursement is less than like plumber or electrician. So what I have noticed in neurologic community who used to do like bread and butter everyday testing, they started outsourcing their testing, even though they are neurologists trained, is not worth for their time. So again, going back to the reimbursement and insurance, all are on the top of prior authorization for those testing. So that hurdle, I would say that let doctor be a doctor and let them practice freely. So
Thank you, Doctor, for your input. And now, Dr. Safi, go ahead. You have a time in front of the legislators, in front of the 120 legislators. Floor is yours.
Again, like my colleague said, this issue is paramount for all medical practitioners now. Insurance companies dictating how doctors practice medicine. In my line of work for macular degeneration, there are different pharmaceutical agents that can be used to treat macular degeneration. And for certain types of macular degeneration or other retinal diseases, certain pharmaceuticals work better than others. However, insurance companies have these programs where you have to use an inferior product that's a lot cheaper first, 3 times on a monthly basis. So that's 3 months that you're not giving patient what's the best medicine. Instead, this is not dictated by medical science. This is dictated by insurance company policy. And this is something that can be changed through legislation. Certain states can adopt changes like that. And that's what our legislature can do to help the patients, to improve the quality of care that doctors know how to provide, but they need to be enabled to provide that care.
Dr. Safi, Dr. Brown, Dr. Patel, thank you so much for stepping up tonight and creating the history. And we'll move forward fighting for you. I'll make sure I push my job and make sure I connect you with the legislators. And I believe together we have to start from somewhere, and that day is today. And from the Rimm podcast, I really want to thank you again for being our special guest. This is a special edition. This is not about the interviewing. This is about speaking on behalf of the doctors and letting the doctors what they're going through. And I'll do my best to deliver this message to the other legislators. And with your help and your expertise, we'll do so many down way on the road with other couple colleagues. Again, thank you so much. I really love you. I really thanking you for stepping up out of your busy schedule and helping us to deliver the message not just to Central Florida, but throughout the nation. Thank you. God bless you all, and I'll reach out to you personally after the show. Thank you.
Thank you, Igor.
Thank you.